Oh, I see
You
it
should
happening
be.
now.
There you go.
Okay. All right, I will get started. So this is my first time doing a webinar, and Eric is helping me. So hopefully everybody can hear me just fine. And we will get started. I think we have pretty much everybody in here. Um, we can use the chat or the Q&A for questions at any point. You guys can just type in. Don't worry about waiting till the end or anything. If I don't see them right away, I'll try to get to them at the end, but I'll try to keep an eye as well. So to everyone here, I'm Carolyn Perot. I am the stroke program manager for Maine Medical Center Portland. I am new to the role in Portland. I was the stroke program coordinator for Maine Medical Center Biddeford and Sanford prior to taking this job. So I have a little familiarity with the crews down there and those processes, but I am new to the Portland area. My background is I was an ICU nurse for 8 years prior to taking that role and then coming here. So my pretty much very familiar with ICU, not so much with the ED, but happy to be here and talking to you guys about stroke. Oh, I just got a chat. Hold on. There's a lot of chats. Oh, okay, perfect. Yep. So just use the chat function rather than the Q&A function. I have no disclosures to discuss. Nobody pays me money except for Maine Health. Some objectives for today. So we want you to understand the prevalence of stroke in Maine, some of the data and trends, and how to effectively assess the local impact of stroke care in the region, understand the purpose of the comprehensive stroke program, our joint commission requirements, and our program goals, and align them with your practices and established standards to contribute to our stroke care initiatives. Understand how your actions will enhance time-critical interventions for stroke and optimize our patient outcomes. Understand adhering to the time goals for code stroke processes, ensuring efficient and timely delivery of stroke interventions that align with best practices and established benchmarks, and effectively communicate the assessment findings with the hospital. So how to pre-alert us. So a little bit about a comprehensive stroke center. So in 1996, the National Institute of Neurological Disorders and Stroke found that stroke patients treated with TPA, and that was alteplase, what we used to use as a thrombolytic, were at least 30% more likely to have minimal or no disability at 3 months. And this is when most of stroke care changed. So prior to that, there were really no treatments for stroke. And then in 2014 and 2015, 5 clinical trials supported cerebral thrombectomy for large vessel occlusions for up to 6 hours from last known well. And then after that, we had a few trials that supported up to 24 hours from last known well. So the most recent trial that we had in thrombectomy care was the DAWN trial, and this extended our window for thrombectomy up to 24 hours. So patients who meet imaging and LVO, large vessel occlusion criteria, and have enough adequate brain tissue that can be saved will go for thrombectomy up to 24 hours from last known well. This map kind of shows overall in the state of Maine, some of our strokes. It's pretty widespread. We have about 3,000 annual strokes per year spread throughout the state. Every acute stroke needs rapid evaluation, imaging, and quick decision making to preserve any brain tissue and neurons. We don't have a lot of neurologists in Maine, and they're pretty much concentrated in the central Portland, coastal, and southern region. The far north you go, the less availability there is for neurologists. And Portland is the only comprehensive center in the state of Maine and the only thrombectomy capable center in the state of Maine. So it puts us in a unique position where we get patients from all over the state. If you think about other states like Massachusetts, or even a little bit further south, North Carolina, a smaller state for one, and for two, North Carolina has 3 comprehensive stroke centers. Within about a 40-minute drive from each other. So it puts Maine in a little bit of a different situation. Most of the emergency departments bear the brunt of the initial acute stroke management, and the ED providers in rural areas are often a little bit more unfamiliar and a little bit more I can't think of the word, a little bit less familiar with handling strokes and how to care for them. So, as I mentioned, Maine Medical Center is a comprehensive stroke program. We have been certified by the Joint Commission since 2017. Prior to that, we were a primary stroke center. So you guys are aware the other primary stroke centers within Maine Health are Biddeford, Midcoast, and Penn Bay. Being a comprehensive center means that we can care for the most complex stroke patients. We can provide all required services. We are available 24/7 to do thrombectomies, brain surgery, anything that is needed within stroke treatment. Again, we are the only comprehensive center in the state of Maine, one of only 5 in New England. And we are the only hospital in Maine providing thrombectomy treatment. We average about 900 ischemic and hemorrhagic stroke patients annually, so we're pretty busy here, this hospital. Again, like I mentioned in the previous map, we get patients from all over the state, so they tend to cluster here. Our mission here is to deliver the highest quality full spectrum stroke care that integrates the multifaceted needs of cerebrovascular patients, including rapid and appropriate treatment of stroke patients, high complexity state-of-the-art neurosurgical, neurocritical, and neurointerventional care, efficient, flawless inpatient care, and appropriate rehabilitative and outpatient services, community education, and prevention. All right, so to talk about stroke a little bit, it is the 5th leading cause of death in the United States as of 2022. It's the leading cause of serious long-term disability in adults, and it reduces mobility in greater than 50% of stroke survivors ages 65 and up. It represents one of the largest healthcare costs, $70 billion per year. And a stroke occurs about every 40 seconds in the United States and about every 3 minutes and 14 seconds. I say every 4 minutes to kind of keep 40 seconds, 4 minutes. There's a stroke-related death. It's estimated, and this is super important and what I think gets across to a lot of people the most, is that on average, approximately 2 million brain cells die every minute the blood flow is disrupted to the brain. And there are about 86 billion neurons in the human brain. So that's why you will commonly hear that time is brain and why we are so adherent to our time goals in stroke care, because we want to preserve as many of those neurons as possible. Different types of strokes. We have your ischemic stroke. It's most common. It's about 80 to 90% of all strokes. Can be atherosclerotic vascular disease, so internal carotid artery stenosis, those small vessel diseases in the brain. Cardiac embolism, so your AFib patients, throat clot. Cerebral small vessel disease again, so lacunar strokes, those are small strokes deep in the brain structures. You can also have arterial dissection, vasospasm, blood disorders, infections that can cause strokes in the brain. One that we see pretty often is endocarditis, and we'll see infective endocarditis throw off septic emboli to the brain that acts very similar as those cardiac embolisms in stroke. Your hemorrhagic stroke is about 10% of all strokes. Can be intracerebral within the brain. The vessels rupture, mostly caused by untreated hypertension. And then your other is subarachnoid hemorrhage. These are vessels on the surface of the brain that rupture, and it bleeds into the space between the skull and the brain. Um, Most commonly caused by cerebral aneurysms that are unknown, but can be hypertensive. Um, there's lots of arteriovenous malformations, things like that. This is an example of the cardioembolic ischemic stroke. So again, those AFib patients tend to have blood pool and clot, and then in the left atrium, and then it will get dislodged and go up to the brain. Goes up to the brain and blocks a vessel somewhere, and then you have no blood flow beyond that blockage, and the brain tissue begins to die. So stroke signs and symptoms. It's going to be the sudden onset. This is important because it's going to help you determine your last known well times as well. But what we really kind of focus on is that sudden acute onset of weakness on one side of the face and or limb. So that one-sided weakness, numbness, tingling, loss or reduced sensation, not bilaterally, but again, unilaterally. Speech disturbances, so slurred speech or dysarthria, impaired language, your aphasia patients. Aphasic patients can be very difficult to assess at times because we're not sure if they're not understanding us because they're aphasic or because there's another issue going on. Persistent dizziness, vertigo. Your dizziness and vertigo are generally signs and symptoms of a posterior circulation stroke, so strokes that are occurring in the back of your brain. A big kind of trigger with dizziness related to stroke is that it is not triggered by changes in position, and it doesn't get better by changes in position. So it's a constant dizziness that doesn't get relieved by anything. Uncoordinated movements of a limb, both limbs, leg or arm, gait disturbances, difficulty walking, painless loss of vision in one eye, or a loss of field of vision, double vision. Some people can be really hard to assess their loss of vision because of the way the body compensates. So they may just describe their vision being different or funny, but not really being able to say, I can't see my lower left field of vision because their body doesn't realize. Sudden onset severe headache with no other apparent cause. Again, you'll hear the worst headache of my life, or that thunderclap headache can be a common symptom of the subarachnoid hemorrhages. And then confusion or agitation usually happens later on. Some of that confusion can get misinterpreted as confusion, and it's really aphasia. But so considering that as well. Our window of opportunity and our time goals. So from an EMS perspective, all stroke patients are considered acute stroke patients for up to 24 hours. We have potential life-saving and function-saving measures for up to 24 hours. So anything within a last known well of 24 hours, consider this an acute stroke that needs to be assessed immediately. Our window for our TNK, tenecteplase, our thrombolytics, is 4.5 hours from last known well. And then our window for thrombectomy is 24 hours from the last known well. The FAST ED screening gives a good indication of the presence of LVO, but only imaging can really diagnose an LVO. So a higher FAST ED score can sometimes trigger us to think there could be an LVO present, but we need that CT angiogram to diagnose it. All stroke patients with an unknown last known well or the last known within 24 hours should go direct to CT with EMS pre-notification. The kind of imaging that we do really are CT head with no contrast is going to show us if there is a hemorrhage in the brain. If there is no hemorrhage, they are eligible for TNK potentially. Our CT angiogram, the one with dye, is going to tell us if there's a large vessel occlusion, and then they might be a candidate for thrombectomy. And then the last imaging we do is called a CT perfusion scan. And this shows us the size of the core infarct or already dead tissue versus the penumbra and the tissue at risk. So how much of the dead tissue is already dead due to the loss of blood flow, and how much could we save if we remove the clot. And that kind of guides our interventional radiologists if whether or not they're going to take them for thrombectomy. So to see them a little bit more, you see in A here on the top left, you have a CT head. This is a non-contrast CT head. On the right, there you can see already some early ischemic changes in the left insular of the brain. So if we see this on imaging, it shows an already or almost completed stroke. I'm going to let Eric, I'm reading the question. Is the expectation that EMS clinicians deviate from main EMS protocols for the time frames? What do you mean exactly? Like, guess I don't understand.
So their protocols actually specify some specific timelines, whereas our time frames are actually different. So yeah, and I think that's the key. So we basically do direct to CT, and we allow for anything up to 24 hours because we'll take anything from that. And I think some of it is they're working off like the 3 to 4 hour window frames for TPA and things like that. So the intent is not to have them deviate from their protocols per se, but also to recognize that we will take patients that don't meet the main EMS protocol standard. Ashley, if I didn't cover that, feel free to chew me up in the box. Ashley is actually the CARES coordinator for the state of Maine. So
yeah, so I think, and I would agree, I think here in Portland, we, especially because we can do the thrombectomies, we would like early notification of those patients within the 24-hour time frame. But I understand that the main EMS protocols are different. I'm happy, Ashley, to advocate for you in any platform for that as well. So please let me know. So looking at our image in the top left, image A. So this is your CT head non-con. This shows some early ischemic changes. Because of this patient probably wouldn't be a thrombolytic candidate because they already have dead tissue that could potentially bleed if we reperfuse with thrombolytics. So sometimes in our CT head non-con, we either see a completed stroke that we won't give lytics to, or we see a bleed that we won't give lytics to. On our top right here in B, this is a CT angiogram. So this is when we put the dye in, and it shows us the vasculature of the brain. The arrow is pointing to what we call left MCA stroke, large vessel occlusion. So you can see how it the blood flow stops right there where the arrow is. And then C and D are both diagnostic cerebral angiograms. So C is a cerebral angiogram. This is done in the IR suite where they inject dye, and you can see that the occlusion right where the arrow is, that there's no blood coming off there to the left. And D is post removal of the clot. You can see all that blood flow get restored to the brain. So this is pretty good depiction of that, which can be really amazing to see in real time. And this is a picture of a clot after they have removed it. Our TICI scores, so this is for our thrombectomy patients. They get a TICI grade based off of the blood flow in the brain. So a TICI 0 is no flow, right? So the flow is stopped. There's no flow beyond that. And then that's generally the patients that go for thrombectomy. And then we score them after thrombectomy. So you have a TICI 1 through TICI 3. TICI 1 is our perfusion past the initial obstruction, but it's limited into the distal branches, and you still have pretty slow distal perfusion. TICI 2 is separated into 2A and 2B. 2A being perfusion in less than half of the vascular distribution of the occluded artery, and 2B is half or greater of the vascular distribution of the occluded artery. And then TICI 3 is full perfusion with filling of all branches. So that is what we aim for. As far as our stroke certification and our measures, they really look for mostly 2Bs or higher are considered sufficient and successful thrombectomies. So the role of EMS, EMS plays a huge part in our stroke morbidity, mortality, as well as how fast we can get to see these patients. Approximately 65% of patients that come in with stroke utilize EMS to enter the healthcare system, which honestly, I wish it was more because the times of patients that come in via EMS versus walk-ins are dramatically different. Patients presenting via EMS are the majority of patients that arrive within the therapeutic window. So generally the patients that are walk-ins are outside of the window for lytics or thrombectomy. EMS utilization is strongly associated with reduced time from onset of symptoms to hospital arrival, and it's strongly associated with decreased time to physician contact, initial CT imaging, and definitive treatment. Where you can make a critical difference, so your initial assessment and identification of stroke, so following the main EMS guidelines can help you rapidly assess and identify potential stroke. Early notification to the hospital triggers the hospital's response system. So here in Portland, we have a direct to CT process for those patients. If you are bringing patients to other hospitals, they might be a little bit different. However, you notifying them early with clear, consistent wording can help them activate their stroke response and speed up that process. The severity scoring and identification of LVO, so fast CDs greater than or equal to 4, can indicate a potential large vessel occlusion, which is important to communicate with the accepting hospital, as they may bypass certain levels and activate other things to speed up the process. And then expedient transfers to definitive care at the most appropriate facility. So knowing that Maine Medical Center Biddeford can't do thrombectomies, but Portland can, and where you are in relation to those hospitals. And then managing the ABCs, getting labs, getting an IV, blood pressure, all of those things can help save time when they get to the hospital to help get them their treatment faster. So key components, what are the symptoms? Why did they call? What symptoms did you notice when you got to the patient? Are they still present? Have they changed? Are they different? When did they start? Last known well is huge in our determining of symptoms. Time last known well, I like to focus on is when they were last normal. So this can be difficult if a patient says they woke up like this, their last normal is going to be the night before, or patients that it's very kind of difficult, nobody's seen them, nobody's been around them, but they were found like this. It can be difficult to determine their last known well, but it is not when symptoms started necessarily or when they were found with symptoms. It's when they were seen last normal. Sometimes when it's witnessed, it can be pretty straightforward. It is symptom onset, but not always. Focused exam findings. So what are you seeing? Focused medical history. What's their risk for stroke, hypertension, hyperlipid, smoking, AFib, things like that. Medications. Are they on any blood thinners or anticoagulants like Eliquis, Coumadin, Lovenox? Sometimes people are on Lovenox at home. Those can help determine treatment options for the providers in the ED. So again, their time last know. When were they at their baseline? So sometimes patients can tell you, but they might be the least reliable source. So validating with witnesses. It's imperative that the contact information for the family or witness of the event is known so that the provider can communicate with them as well. So putting the name, relationship, and contact number is helpful for us to determine any other information needed and verify some of that last known well information before we give the medication. Facilities, so nursing homes, things like that, again, having that written down. If the staff member, writing the staff member's name down can be helpful to expedite that process too. So your Cincinnati pre-hospital stroke scale and your FAST ED 4 or higher could be an LVO. You can bypass other facilities if less than 30 minutes away. So again, remembering that Portland is the only hospital that can do thrombectomy. So if you are close enough, you can bypass Biddeford to come to Portland if you have a FAST ED of 4 or higher. Here are your towns and cities within 30 minutes of Portland. I think it depends where you are sometimes. Three lytic candidacy questions. This can really help our providers speed up in the ED if we have some of the answers to these questions. So this is your stroke checklist. So time of symptom onset, time last known well. Have they had recent trauma, surgeries, or procedures in the last 3 months? Knowing what it was is helpful. So any severe head trauma, intracranial or spine surgery, or major surgery is helpful to know. Any bleeding problems in the past. So history of intracranial hemorrhage, GI bleeding, GI malignancy, or things like that. And then are they taking any anticoagulants? So oral or injectable medications. Now, I mean, I'll say that these don't mean that we will not give lytics if the answer is yes to some of these. However, that's for the providers to determine, and any information they have is valuable. So having these top 3 answered can speed up the process. And you can use the lytic worksheet to fill out all of this stuff as well. So anticoagulants, this is just for your information. We have a full-size laminated sheets with these worksheets in each ring. Perfect. There are distinctions, so between the anticoagulant and antiplatelet medication. And again, it may depend on the lab test and when the last dose was taken, if the patient is a candidate for thrombolytics. But I think it's helpful for you guys to know these are very common anticoagulants prescribed outpatient for warfarin, Coumadin. Depending on the INR, we will still give lytics, so that's not an automatic exclusion. And then antiplatelet medication, so aspirin and Plavix are not anticoagulants, so that does not is not a contraindication to lytics if those patients are on those. So it's really just this anticoagulant group. And again, there's more and they change. So this isn't all of them, but these are some of the most common. Knowing when they last took it is helpful. So if they took it that morning versus if they took it yesterday morning and they didn't take it this morning can help too, because they might be a candidate in that situation. So stroke pre-notification, this is, to me, one of the biggest parts of it. You can do all the right things before, but if you don't notify us, then we can't be ready for you to come. So for Portland, it's direct to CT notification. So while you're in the back of the ambulance managing the patient's needs, you can screen for the inclusion-exclusion criteria, have their name and date of birth ready, call REMIS, and start with code stroke direct to CT, and request to speak with the attending physician, and then provide a report to the attending physician of signs and symptoms, last known well, vitals, blood glucose, and then any other pertinent information you think they may need to know. So that helps the team waiting, get ready and prepare. CT will clear the table so that you're not waiting for the CT table to open, and you can go directly to CT with these patients. Early notification is better. So you call with your ETA and that will go out in the page. So the providers don't just come down as soon as the page goes out, they'll page out the ETA. So we have kind of an idea. And it should happen at least 10 minutes prior to your expected arrival. Patients need 2 large bore IVs. One IV is acceptable as long as it is at least a 20 or greater in the mid forearm or up. So avoid the wrist and hand. They need to be pressure injectable, high ability to handle a pretty significant flush. And the CT techs do like to see blood, but that's not a necessity. But the 2 large bore is definitely the preferred. So important timelines for us. So our door to activation of code stroke is 10 minutes. Our door to CT is less than or equal to 15 minutes. Our door to thrombolytic administration is less than or equal to 30 minutes. Our door to, okay, so door to needle is technically, is our thrombolytic door to groin puncture, I guess that should say, is less than or equal to 60 minutes. And then door to reperfusion for our thrombectomy patients is less than or equal to 90 minutes. Rarely do our walk-ins meet these time goals. It truly is dependent on EMS activating early to get us to these pretty expedited time goals. Again, your documentation, this is kind of our TNK eligibility criteria. If anybody knows Dr. Morris, she loves making these sheets with all the information you could possibly need to know related to stroke care. So there's a lot in here that's not for you guys to necessarily determine, but the more you know, the more information you can provide can help make the decision happen quicker. So some other considerations. So interfacility transfers. Because Portland is the only comprehensive center, we receive patients from all over for thrombectomy care, but also for just neurocritical care. However, in 2024, we had 302 patients transferred for endovascular consideration. Most of these patients will need repeat imaging when they arrive to see if they are still a candidate for thrombectomy. Most of them will need a CT, CTA, and then pretty much All of them that are not from Biddeford and Sanford will need a perfusion scan. Biddeford and Sanford went live with perfusion capabilities in 2020, in a year, no, a little in 2024, September 2024. So now Biddeford and Sanford are capable of doing perfusion scans. So if a patient is accepted to thrombectomy from either of those locations, they can go direct to IR. So that's an important terminology to know if you have a patient coming. Biddeford and Sanford should be pretty clear about that. But you can always ask if they're going direct to IR, you can bypass the ED, bypass CT, and then you would go straight to IR for these patients, and it reduces the door to groin puncture and door to reperfusion time. If a patient receives thrombolysis at another hospital prior to transfer, then they have to receive post-thrombolysis monitoring. This is frequent vital signs and neurochecks and monitoring for any signs of hemorrhage in the brain or anywhere. So Q15-minute blood pressures, neurochecks to make sure there's not worsening signs or symptoms of the stroke. Severe headache, nausea, vomiting, anything like that would be concerning. If these patients are coming for thrombectomy after thrombolysis and you notice any of those signs, calling ahead to discuss with the emergency medicine provider in Portland can help because they will activate the pathways to get repeat imaging on those patients first if needed, or if it wasn't already planned. And then explaining. So in the back of an ambulance on your ride from Penn Bay to Portland, you may get a lot of questions. So kind of talking about what's going to happen. So for the procedure, they're going to go to the ED. They're going to get another CT scan to find the clot and see if the stroke has progressed. And then they'll go to interventional radiology suite where the doctors will insert a tiny tube through the artery in their wrist or groin, go into the brain and remove the blockage to restore the blood flow. And then they'll go to the neuro ICU to be monitored closely. It's generally a pretty safe procedure, but there are always risks. So they could have bleeding in the brain, damage to blood vessels. The clot could move to another spot. Swelling or worsening stroke can happen. And then very rare serious complications or death can occur. The doctors will act quickly to minimize these risks. And again, the doctors will discuss this with patients and their family members as well. I will say a lot of large vessel occlusion patients are pretty debilitated by their stroke. So, but you can get some that you wouldn't know that they had a large vessel occlusion based off their cerebral, their collateral circulation. So the branches that form to help perfuse the brain in those areas of dying tissue. So feedback reports and case reviews. We are dedicated to improving EMS clinicians as well as the relationship between the ED and EMS. So we work together to provide feedback to Eric based on documentation, the time goals, and how the patient did. We share monthly statistics with EMS leadership, and then I will present some cases as well to just discuss any improvements that could have been made and or things that went really well. So in summary, you guys play a huge role in what you can do to change somebody's life related to stroke, truly. Making sure you're documenting the stroke checklist, making sure you're doing those Cincinnati and FAST-ED scoring tools to assess for suspected stroke, reporting that to the ED, documenting the last known well, 3 lytic questions, and the contact person. Early notification to the emergency department with updates can really make a huge difference for these patients. And anything that you do can inform our team and activate the proper processes to help improve patient care and outcomes. It is really quite amazing when you get a patient that can't move half of their body. They may have neglect on one side, and they get lytics, and then they have a thrombectomy, and then they have no residual symptoms. And that is, you're talking about a patient that would have likely needed to go to a nursing home and been dependent on other people for care, can potentially just go home and care for themselves. So that is such a life-changing event that you guys have played such a huge role in, and already do such a great job at. These are some of the references that I have for all that information. Does anybody have any questions for me?
Oh, all right. I'm gonna throw a evaluation link in the chat for everybody if they could fill that out. There it is. All right. The chat for everybody. There you are. All right. Obviously, if anybody has any questions, you are more than welcome to reach out to us. If you don't feel comfortable asking them now, you can email myself or Caroline. We can definitely get you the answers that you need.
Yes.
Well, I guess that's our performance for today.
All right. Well, thank
Caroline,
you. I really appreciate it.
Thank you for doing this.
Yes, of course.
Absolutely. All right, everyone. Have a great day.
Thank you.